Hi everyone, it's Heather. I know that there are a lot of people who have just gotten accepted into programs or they're about to have orientation, but quite a few people who are starting in the fall who have posted. And I just thought that I would do a little bit of a video about my first bit at school. I know that last year at this time I was um, excited and anxious, but really curious about what school was going to be like. So I thought I would just do hopefully not a super long video about what school was really like, kind of a day-to-day thing as far as classes, and then once clinical started, some things about that, just to give new students a little bit of an idea. So um, if you haven't been to orientation yet, I know that that's like the first big step, and everyone's very excited about that. My orientation was really boring. Basically, we talked about our schedule, we talked about what books we would need, we talked about what our uniform and supply needs were going to be, and there was a lot of paperwork. There was a lot of just filling out papers. I know some places do like a Q&A with second year students. Mine didn't. There was just a lot of stuff to go through in that amount of time, and I think they felt like they just didn't want to add on to the amount of time that we were there. And I'm sure most people this year are doing virtual orientation anyway. You're not actually going to the school or anything. So if you've had an orientation already, yay! Very exciting first step. Things to think to ask, make sure that you know what your schedule is going to be like. Make sure you know what books you need. If you need scrubs, I know some programs start clinicals in their first semester. Mine did not start clinicals until second semester, and they had told us not to buy our scrubs yet, just in case we didn't get to clinicals, in case we didn't make it through that first semester. So, as far as what other stuff you need, if you need a stethoscope right away, if you need, whatever other supplies your particular program might want you to have. So that's what orientation was for me. Mostly paperwork, boring stuff, scheduling. That was really it. And then when you get into classes, the first semester is a lot of terminology. It's a lot of information the first semester. I think that so far that first semester had the most stuff, the most papers, the most reading, the most just new material, because obviously you don't know anything going in. So it was a lot of just that new material and new terminology and lots of it. So that's when, for me, it was especially helpful to use flashcards and things like that to remember all of the new terminology and the values and things that I was learning. It's all really, really basic stuff. And at least in my program, it was presented in a stair-stepping format that made it fairly easy, I thought, to remember. It was just a lot. And there's no getting around that. It's just going to be stuff that you haven't been exposed to before if you haven't been in respiratory. If you've been in the medical field and you've done other stuff, that's going to certainly be helpful. There's probably going to be a fair amount of stuff that you already know that other people may not, but you never know. As far as lab, the first semester, it was very basic skills, hand washing, PPE, which is all of your personal protective equipment, your mask, your gown, your gloves. It was how to put that stuff on properly and how to take it off properly and how to wash your hands properly. It was how to administer inhalers and how to put on masks and nasal cannulas and how to connect things to a flow meter. What it was an oxygen flow meter, what's an airflow meter. Patient safety things, making sure that people have their call button, making sure that their bed rails are up if they need to be, making sure, when you go into a patient's room, if you move things around, that you put them back before you leave, how to take history of a patient, how to take blood pressure. And I will be honest, I have never had to take blood pressure on a patient. As far as like manually taking someone's blood pressure, I've never even had to have a machine do a blood pressure on a patient. They're either on the monitor and it's up there, or they're not, and I don't need it anyway. At this point, that has not been a thing. So yes, we did learn how to take blood pressure. I think that I could do it without any issue. I passed my check off. I don't think it's something I'm going to really use ever, but you never know. Um, that was the first semester of lecture and lab. Basically was, how do things run at a hospital? Who is JACO? Who is the AARC? Who is the NBRC? What things are you allowed to tell people? HIPAA rules, that sort of stuff. All very, very basic stuff, but obviously a lot of it's really important to know. How to calculate how much oxygen is in a tank. If you have a patient on a nasal cannula at 2 liters per minute and you're having to use a portable tank, how long is that tank going to last? Those sorts of things. Yeah, that was basically first semester kind of stuff. Second semester, we got more in depth. Obviously, we had pharmacology, so all about the medicines that are used. We had pathology, about diseases that we're going to see. And in lab, we did more invasive skills. We did intubation, we did trach care, we did suctioning. We started learning about machines, basic machines, not ventilators yet. We did, an IPBB machine, which it's my understanding most people don't even see in hospitals anymore. I think I saw one in a hospital storage room once, but other than that, I don't think I've seen an IPBB machine. That's intermittent positive pressure breathing, I think. So just more invasive types of procedures that we can do. And then as well as things like coughing. You wouldn't think that when you're going into this program, you wouldn't think that coughing and different types of coughs and chest PT and things like that, this is where you're pounding on someone's chest either with your hands or with a special cup kind of thing, or with a machine, or with a vest. Just different ways of loosening up secretions in people's chests so that they can cough and get those secretions out of their lungs. That was a lot of second semester stuff. So we also did like the intubation and suctioning and things like that. So the same sorts of things, just getting more invasive and more advanced, obviously. And that's kind of what lecture was like too, was just, just building on what you learned. So you really do need to understand that the stuff that you start learning, in all likelihood, that's going to be stuff that you build on. So you can't learn this one unit and then think, I'm going to forget that and never use it again. There's going to be some stuff like taking blood pressure that you may never use again. But there may be certain things about doing that you're going to use later on, like understanding what your systolic and your diastolic pressures are, and what those numbers represent. That is going to be something that you're going to use further on. Like we're currently doing hemodynamics, which is basically all about blood and how the blood moves in and out of your heart and your system and everything. So, we're using systolic and diastolic numbers in different ways to get other values. And those are things that you need to know. So while I'm not ever going to take someone's blood pressure manually, in all likelihood, I'm still going to use some of that knowledge that I learned there in other ways. So everything builds. Just expect to have to keep that knowledge in some way in your head, or be able to access it frequently. I highly recommend from the very beginning that you start a chart for yourself of basic normal values and formulas that you need, and continually go over those, because I guarantee you're still going to need that information when you take your board. So learning how to calculate tank duration that we learned in first semester, I still need to know that when I take my board exams after I graduate, because there's going to be something about that on my board exams. So if I have created a way for myself to continually review that information so that I remember it from the beginning of my schooling to the end, then it's going to be a lot easier on me than trying to, cram everything in the 3 weeks before I take board exams. So definitely make it easier on yourself. Make a chart from the very beginning. Keep up with your normal values. Keep up with your formulas, so that you can have that all in place the entire way through, and it's just going to make things a lot easier on yourself if you're not having to go back and look up, how do I calculate this again? How do I, what's the normal value for this again? So that's my biggest tip, is keep all that information in one place. I have two different charts in my computer, one that is all my basic normal values and another one that I am making specifically that relates to mechanical ventilation. So however you want to do it, make sure you do it. Clinicals, I'll talk about that a little bit. Like I said, some programs start with clinicals almost right away. Some programs do what mine did, where we didn't start clinicals until our second semester. Going in, you have to understand that how you learn to do things in lab is going to be different than how you're going to do them in the hospital. So in lab, we learn how to go in and introduce ourselves and ask for patient identifiers, and you gel in, you glove, you do this, you do that, obviously some of those things you are absolutely going to do when you're in the hospital. I absolutely gel in at every room. I absolutely put gloves on in every room. Do I ask for 2 patient identifiers with every patient? I'm going to be honest, no. The first time that I go into someone's room, if I haven't seen them as a patient before, I will make sure before I go in, I know this person's name, I know what medication I'm here to deliver, I have at least a basic understanding of why they're in the hospital, as much as I can. Sometimes you go in because you've been called, hey, this person needs a breathing treatment, and you may not have a lot of time to sit there and read their history and read their chart and figure out why they're there before you go in. But I at least try to have basic information. So, I might go into a room and say, hello, Mrs. Jenkins, how are you today? And at least have some information about who this patient is and why they're there. And of course, before, I'm administering a whole bunch of stuff, I make sure to glance at their hospital band to you have to scan it. First of all, you have to scan their band, but so that I make sure that I'm looking at the right patient, because there are lots of patients who may not be able to speak or may not be able to verify who they are. So you certainly still have to do that. Going into the first hospital room ever to see your very first patient is going to be probably make you a little nervous. You're probably going to be excited and nervous at the same time. And everyone is, I guarantee you. Every other student, every RT has been there for that first patient for that first time. And you're going to make mistakes, and that's okay. You're going to try and put a nasal cannula on upside down, or a mask upside down, or you're going to forget to put gloves on until you start to do something, or you're going to forget to check a patient's pulse, or there's going to be something. And I guarantee you're going to do it numerous times for some of the things. It's going to be a lot about muscle memory. I mean, I've done clinicals, only about 275 hours worth of clinicals at this point. I absolutely make silly mistakes. I forget to to check the patient's band, like to scan the patient's band, or I forget to, I don't know what. You're going to forget to do things. I've seen plenty of people who, forget how to put a nasal cannula on from the time they learn how to do it in lab. You wouldn't think that's a difficult thing to do, and it's not. But it's really easy to think that the nasal cannula goes over the person's head. It doesn't. It goes in front of their face and then around their ears. And I've seen at least 2 other people in my class who have tried to put the nasal cannula on over someone's head at first. It's just, everyone's nervous. Everyone's going to make silly mistakes. Just fix it and move on. It's not that big of a deal. Don't beat yourself up if you make, these silly mistakes. If you try to put a mask on someone upside down or something like that, everyone's done things like that from time to time. So don't worry about it too much. Going into a room to do your first ABG, I guarantee you're going to be shaking, and you're going to be scared, and you're going to, be worried about forgetting something. They always say you hope that the first ABG that you do on someone is someone who's frankly unconscious and isn't going to know any different. I'm trying to remember my first ABG, the patient was conscious. Um, it, it went fine. I've done ABGs now on unconscious patients, on people who were conscious and talking to me, on patients who, yelled about it a little bit, on patients who didn't say a word. So um, it's just going to be something that you get used to. If you are brand new and you didn't know yet, apparently some students do come into respiratory not realizing that you are going to have to draw blood. So that is news to some people. So if you're just about to start your respiratory program this year and you didn't know that already, that is absolutely a part of being a respiratory therapist. Something that is done frequently is doing an arterial blood gas, which so when you go into the hospital and you get an IV or a nurse draws blood or you go get blood drawn for labs or something like that, that's a venous puncture. So that's in the needle going into your vein to draw venous blood out. Respiratory therapists draw arterial blood. So there are specific places where we can puncture to get arterial blood. It's usually in the wrist. It's sometimes up in the pit of your elbow for a brachial. Those are the only places that I've done. You can also do someone's foot, and you can do their femoral artery, which is, like in their groin area. But most of the time we're going to be doing the wrist or the elbow. And that's something that you learn how to do. I think I learned that. I had to have learned that first semester because we were expected to be able to do it when we got into clinicals second semester. So that had to have been at the end of first semester. And that is absolutely going to feel like really, really nerve-wracking at first. And I'm certainly not an expert. Just this last weekend when I was at clinicals, I attempted to get an ABG on someone. I felt radial, couldn't feel anything. And this was a patient who was post-surgical, and she was not coming out of anesthesia well. She was still not responding well. They had put her on a BiPAP machine, which blows air into you. It's positive pressure, blowing air into you if you're not taking breaths deeply enough on your own, or you're not getting rid of enough CO2 on your own. So we had to go down to the post-surgical unit, and they wanted a stat ABG, and she had scar tissue here in her brachial area. I couldn't feel a good radial pulse on either side. The nurses were trying to draw bloods, so I'm trying to work around them. I ended up attempting a brachial because I couldn't feel a radial at all, and my brachial was really just a blind stick. Couldn't feel a brachial pulse, blindly poking where I thought it was. And obviously this is, I have my preceptor who was helping to direct me in what to do and everything, because I hadn't done just a blind stick before. I had always been able to feel a pulse somewhere and attempt. And I ended up getting venous blood. So we were able to at least check her CO2 levels, which was the really important thing that the doctor wanted to know. So that at least was something. I knew from the minute the blood started flowing into the syringe that it was a venous sample, not an arterial, because it was much darker than arterial blood would be. And then later on, they wanted a second ABG, and she had actually woken up more, and she was lucid and conscious. They had given her Narcan to reverse the effects of the anesthesia because she just wasn't coming out of it as one might expect. This was, I think 3.5 hours after her surgery was over at this point. And so by the time we went to do the second ABG, she was conscious and she was doing much better. But the doctor just wanted to see how much her CO2 had gone down at that point. And I'll be frank, I asked my preceptor if she would do it because I just knew from already feeling this lady's pulses from before that I was going to have a really hard time doing it. And with her being conscious and awake, and it was the first time that I had said, I don't feel comfortable doing this one. And so my preceptor did it, and she did actually get a radial on that one, but she said that she was also doing a blind stick at that point, that she hadn't really been able to feel the pulses properly. So that's going to be a thing sometimes. Sometimes you are just going to say, I really don't feel comfortable with this, but really, really try not to say that. If it's just something where you're a little bit nervous, and I probably could have tried that second time, but you know, I just didn't feel comfortable with it, with knowing that it was going to be another blind stick. I probably should have tried it, but what can you do? So try not to say, hey, I'm not okay with this, unless it really is a matter of you feeling like it wouldn't be good for your patient for you to do it. If it's just like oh gosh, I'm super nervous to do this ABG, or I'm super nervous to help with this procedure, sometimes you need to just go through those nerves. You just need to keep going despite that. So first code. So I saw on Facebook recently someone who said that they had been at clinicals for like 2 years. I don't know what kind of program they were in, and that they had yet to go to a code. They'd been doing clinicals for all this time and still hadn't gone to a code. I don't know if they were working in a really small hospital in a really small area or what, but I mean, I think I went to my first code in my first week of clinicals. It's not like I've been to them every time I've gone to clinicals, there's been a code. There hasn't. I think I've gone to only like 1, 2, 3. I think I've only been to 4 codes. But certainly I've been around the hospital when there have been codes, and there were others that, we got there and there were already enough people and they didn't need us. But I went to my first code where I was actually part of doing CPR and using a Doppler to find a femoral pulse later on. It was a really interesting experience. So that's another one where you need to be aware of what's going on. You need to listen to what you're being asked to do, and you just need to try it. You just need to do it. So when we first got in there, to the very first code I went to, they were actively doing CPR when we arrived, and I rotated in on doing compressions. So, if you haven't taken, I'm assuming everyone has taken at least a BLS course and learned how to do CPR by the time they're going into their respiratory therapy program. But if you haven't, doing compressions can be really, really tiring. And so you try to have multiple people who can cycle in to do compressions to make certain that you're giving compressions in an effective manner. Because if you have someone who's really, really tired trying to give compressions, they're probably not going to be doing it effectively. So I rotated in to give compressions. And then later on, when CPR was started a second time, I was actually given a Doppler, which is, how when a woman is pregnant and they can put the little wand on her belly and you can hear the baby's heartbeat, that's a Doppler. So you can use a Doppler to find pulses. So I was holding the Doppler in the area where the femoral artery was. So basically, as they were doing CPR, you could hear the heartbeat on the Doppler, because CPR was forcing that blood through their system, was forcing their heart to open the valves and get the blood pumping throughout their system. And so I would hold the Doppler onto the femoral artery so that we could hear the pulse while they were doing CPR. And that way, when they stopped CPR, because this particular patient, we were unable to feel pulses on, you could kind of get a carotid pulse at one point, but in holding the Doppler at the femoral artery, when they stopped CPR, we could tell more than just trying to feel it, whether or not there really were pulses when CPR was stopped. So, that was my job at that point, was just to sit there holding this Doppler thing in this person's groin to see if they still had a pulse when CPR stopped. So, sometimes you just got to jump in and you have to say, I'm willing to do this. Give me a job. What do you need? What can I do? Even if it's to, I've done bagging, I've assisted with intubations. You just have to be willing to do it. If you don't show that you're proactive and that you want to do things, you're not going to get that experience. And you really want that. So I think that this video has gotten really, really long, but I just wanted to give you a little bit more information about what to expect from your program if you are a new student. And I hope that everyone starting this fall has a really great time. I know it's going to be a little bit different with COVID and virtual classes and things like that, but drop me a line, let me know if you have any questions, and hope you enjoy this.